So thank you everybody for joining us today for another UCD Lunch and Learn. Today I'm joined by Dr. David Ramirez. He is with South Texas Research Institute, and he has a rich history. He's born and raised in the Valley. So further ado, thank you for joining us, Mr. Ramirez, and we appreciate your time.
Hey, I appreciate it, Mr. Davis. Thank you for allowing us to come in and present today and just share some of my slides. They're a little informal, some of them, so I appreciate you allowing us to come on. So, like Mr. Davis was saying, my name is David Ramirez. I'm from the Valley. I'm from Mission. Went to Mission High School, Go Eagles, and then to UTPA. And was a high school teacher for a few years, went to medical school after that, and came back for my residency here at DHR in family medicine. Stayed on as a hospitalist for a few years, and then throughout the pandemic, and then got recruited over here to STRI. And here at South Texas Research Institute, or STRI, what we do is clinical trials. So these are medications. About 95% of our studies, these medications are targeted at fatty liver disease, and there are 4 stages of fatty liver disease, and I'll get through the stages right now in one of my slides. But we have studies aimed at each area, and kind of like Unidos' mission of attacking diabetes, for instance, in that pre-diabetes stage. The same as our mission is to try to find fatty liver disease when it's still relatively early, and hopefully through a combination of both diet and lifestyle changes, because we know that diet and lifestyle are the cornerstone of not only prevention, or not only treatment, I guess, of metabolic diseases like fatty liver disease, diabetes, high blood pressure, high cholesterol, obesity. We know that it's a key to prevention, right? And those of us in this community, South Texas, the Norteño community, the Latino community, the Mexicano community, we have a high risk for obesity, metabolic diseases, type 2 diabetes, etc. So prevention needs to be rooted or ingrained, I guess, in our cultures, in our kids, in the next generation, to prevent this. As a hospitalist previously to this position, I would see a lot of the sequelae, a lot of the problems that come from undiagnosed fatty liver disease, especially in what we call decompensated liver cirrhosis. So the whole end game here is fatty liver disease, which starts off in the first 3 stages out of the 4 stages as very benign, very asymptomatic. There's no pain, there's no issues, you don't even know it. Maybe your family doc will pick up some elevated liver enzymes in the blood work here and there, but they're not high enough where we'd be concerned that there's a hepatitis, for instance, going on, or an autoimmune condition going on. Is there just a little bump? And as family medicine, I had a great residency, great training, but it's a huge field, and so a lot of times we chalked it up to probably fatty liver. Sir, please change some, lose a little bit of weight, control the diabetes a little bit better, etc. And I'm not sure if the importance of fatty liver disease and trying to prevent the progression. Ultimately, the stage 4 fatty liver disease is called cirrhosis, and it's the same cirrhosis that patients that have alcohol use disorder, or previously used to drink a lot of alcohol, or even still do. It's the same kind of cirrhosis that they can develop. And so that's our end game, is to try to prevent that progression. Now, thankfully, it's only a small percentage of patients that will progress through the stages, and we're still trying to understand in the clinical world and in the preclinical world, what genes, for instance, are responsible for either protecting or causing us to be more likely to advance. We have a study actually with one of the genes, HSD B1713. I might be butchering the name, but it's a study aimed at looking for that gene. There's another one, PLA3, that we have a study that's coming up that's going to be aimed just at looking at that gene and its function, of how it either provides protection or how it advances the disease. So all that's to say, this is a treatable and preventable disease in the sense of diet and lifestyle, but as currently there are no medications approved to treat fatty liver disease, and we'll talk about it. So fatty liver disease is a accumulation of fat in the liver. We're supposed to have a small amount of fat in the liver. It's healthy. We use it for energy. That's okay to have a small amount. But when we have more than about 5% fat in the liver, it becomes toxic. The fat cells get confused by the immune system. and for invaders, I guess you could say, and there's an immune response, and so the white blood cells, the macrophages, all the inflammatory cascade begins to happen, and the fallout from the cascade of inflammation, I guess you could say, is a thickening of fibrosis and inflammation of the liver. So we know that very rarely is this caused by medications. A lot of times we hear in everyday language, so much medication, tanta medicamento, but rarely do we see that it leads to at least fatty infiltration of the liver or damage from fat accumulation. Now, medications and other issues, if taken incorrectly, can cause problems, but that is not the type of insult or damage that we generally see in fatty liver disease. So very prevalent issue. NAFLD, non-alcoholic fatty liver disease, we'll just call it fatty liver disease. The inflamed version is called NASH, or non-alcoholic steatohepatitis. So, but I'll kind of use those words a little bit interchangeably. So it's very, very prevalent. It's extremely prevalent, especially in the Latino community, this area of the world, and then also in the Middle East, but prevalent across the world. This is a metabolic disease that goes beyond state lines, country lines. This is a world problem. 25% of the world's population have some level of fatty liver, and 30% of the US population. I'm not aware of specific epidemiological studies here in the Valley, but definitely I would estimate that the percentage is much higher. My mentor from medical school has a practice here in Mission, and family doc, awesome. And she would tell me, David, everybody that walks in the door has diabetes until proven otherwise. And she's like, you need to get checked. Go see your family doctor and get checked immediately. And it's in that type of mentality, that it's present in so many of us, and it's just this brewing kind of bubbling issue, and it doesn't come to light until, just like diabetes. Diabetes oftentimes brews for many years, 10 years often, without patients having significant symptoms. And so same thing for fatty liver disease. The big, like I said earlier, the end game is to try to prevent liver cirrhosis, and even advanced fatty liver disease like NASH. The more inflamed, the more aggressive form of fatty liver disease increases your risk of liver cancer, hepatocellular carcinoma. It's also the number 2, I believe, the number 2 reason for liver transplant. Like I said, when I was a hospitalist, I would see a lot of patients with the end stage problems of liver disease, the cirrhosis, and even the liver tumors, and they would tell me, "Pues mijo, nunca me tomo mucho." Never did I really drink heavily, and it likely developed from fatty liver disease over many, many years, even decades. So we know that the risk factors include obesity, type 2 diabetes, high blood pressure, high cholesterol, hypothyroidism even has been linked to fatty liver disease. As a result of the metabolic issues, obstructive sleep apnea, a lot of us, it's another condition I'm passionate about that I suffer from as well, that I didn't know I had until I was in medical school, by the time I found out. But it's a condition where at night people may snore excessively and oftentimes stop breathing, and that reduces the amount of blood flow. I think when I did my sleep study, I was desaturating, my oxygen level was going down into the 60s, something crazy like that. And it causes issues for sure. That's linked to fatty liver disease as well. Risk factors again, men and women. Men tend to be overrepresented, excuse me. Other risk factors, like I said, obesity, being over the age of 45, being Latino, Hispanic. The prevalence in high-risk populations. So we see this fatty liver disease some stage, right, in patients that have obesity, patients that are diabetics. We would say that 60 to 70% of them have some level of fatty liver disease. If you have more than one of these risk factors, let's say that you have obesity and diabetes, for instance, that stacks, right? That increases your risk, it multiplies the risk. And so we see this, like I said, very prevalent down here. This is a quick histopathologic slide, or slides, and showing just some of the progression from a normal liver, sorry, this one's active, a normal liver here to, very different. Now, I'm not a pathologist, right? The last time I really looked at slides, under a microscope was back in medical school and occasionally in residency. But I mean, just from the naked, eye, quite a difference between this healthy looking liver and all of this inflammation and basically scar tissue, right? As it's gone through the process. And so and then the gross liver. So looking at the liver as a whole, this nice, beefy looking red liver, and it really does change my cadaver in medical school. The patient I remember had a history of obesity and type 2 diabetes, and that person's liver looked a lot like this liver. I remember grossly looking at it during my lab work, and I remember thinking, I was like, hey, how come our liver doesn't look like this one over here, like the normal liver? And that opened a whole discussion on fatty liver disease, and our instructors, were waiting for one of us to uncover that. So, yeah. So most patients are patients. So the natural history of fatty liver disease, right? The majority of us, it doesn't progress. The majority of us, we stay at level 1 or 2, thank God, or thankfully. But overall, studies, epidemiological studies, meta-analysis have shown that fatty liver disease at any stage increases the risk of mortality, right? Increases the risk of death overall. As we progress in the stages of fatty liver, so from F1 stage to F4 stage, right? There's 4 stages, F0 being, I guess, normal. Each stage as you progress up increases your overall risk of death. And these risks of death are mostly cardiovascular related, so heart attack, stroke, those kind of things, other issues. And then of course, cancer related. We know metabolic diseases in general, like diabetes and obesity, and increase our risk for certain types of cancers. Colon cancers are one of them. Okay. So here at STRI, we have different clinical studies that are involved in kind of trying to interrupt the pathogenesis, the disease progression of fatty liver disease. Industry, right? So pharmaceutical companies, which we work with big ones and medium-sized and even smaller ones throughout the gamut. They're all regulated by the FDA, and the majority of studies we have are phase 2B or even 3. And so they're more advanced. They're in hundreds of patients around the world, usually hundreds of sites, usually around the world. And so each medication has like a different pathway, I guess you could say, or different like a attack method. Some of the medications are involved in trying to kind of pull some of that fat out of the liver directly, or reduce the amount of fat that accumulates, I guess you could say, in the liver. Some of them are aimed at some of the medications are aimed at trying to reduce the inflammatory component. Some of them are trying to reduce the amount of like fibrotic tissue or scar tissue, I guess you could say, that is forming in the liver. Remember that there are no FDA-approved medications available just yet for any of these stages, right? We can treat the symptoms of, like, for instance, liver cirrhosis, right? But we don't have a medication that can reverse it yet, or that can directly treat it, or any of the other stages of fatty liver disease. And so all of these are different. If you have a biochemistry background, molecular biology, or even just curious, I mean, all of these are potential targets for medication to interrupt. Now, we know also that diet and lifestyle help to down-regulate some of those things as well, right? So the type of dietary changes that we recommend, and I'll get into it in a little bit, but we recommend a little bit less carbohydrate intake, right? Those carbs that we eat kind of go into our GI system. They get transferred over through absorption from the small intestine into the liver for that first pass, right? So the liver can detoxify whatever we're eating or drinking. Well, the carbohydrates get broken down into their monomers, into their single sugar units, and then they get reformed, 3 carbohydrates with a cap on top, to a triglyceride. And a triglyceride means exactly tri-3-glycerin or glyceride sugar. And so it's 3 sugar molecules, and it gets turned into a fat. And it's those triglycerides that get incorporated directly into the liver and cause that toxic effect, cause those inflammatory issues, cause the scarring type of thing that goes on. So again, just another picture of how it progresses over from a normal liver to simple fatty liver, which is non-alcoholic fatty liver, NAFL, to non-alcoholic steatohepatitis, NASH, or the more aggressive inflamed form, and then to cirrhosis, right? And now, thankfully, like I said earlier, it's only a small percentage of us that will progress. But the problem is that even a small percent times probably billions of people, right, around the world that are affected is a huge number of patients, huge number of people that are without options. But like I said, diet and lifestyle are our primary treatment models, and I don't think that that's going to go away. That's going to need to be a necessary part of treatment for this disease, probably in perpetuity. So what can we do, right? So I mentioned earlier that here at STRI, we offer free services to community. And one of the services that we offer are free fiber scans. So, and we offer the fiber scans, which is a small, we don't have the big unit here, but we have the smaller portable unit so that we can take them to community events. And if there is a health fair, we're probably going to be a part of it. And if we're not, please call us so we can be a part of your health fair. We love to go and set up booths and provide, swag stuff, information, materials. And then we also do free fiber scans on people. So the fiber scan is it's a vibration controlled transient elastography device. It's a small mini ultrasound, I guess you could say, that sends a beam of sound into the liver, and it vibrates the liver. And based on how the liver vibrates, we can tell the fat quantity of the liver, and we can tell how stiff the liver is. Yeah, so it's painless, and I'll get to a report right now, but it's a painless, quick, takes about 5-10 minutes at the very, very most. And with a more experienced operator, which our technicians are very experienced, and they've done hundreds of thousands of these. It's a very quick, it doesn't hurt. The patients do have to be fasting for about 3 hours before. Water is okay, but nothing else besides water for 3 hours. And the reason why is because when we eat or drink something, right, the liver increases the amount of blood flow going to the liver because it's expecting a meal or something to process, right? It's getting ready to process some food. And that increased blood flow kind of stiffens the liver, so the numbers might come out a little bit higher than they should. And so here's a sample FibroScan report. The blue number over here is the quantity of fat in the liver. Normal is about 280 or less. And that indicates if you're 280 or less that you have a fat component of less than 5%. Remember that 5% is the healthy level of fat that we're supposed to have a little bit. We use it for energy, a little bit of cushioning of the organ, right? If it's above 280, this cap level or this attenuation parameter, then it means that we have more than about 5%. And so we have fatty liver. The more important number is this red-orange number over here, the 3.5 in this case. And that's the stiffness component, I guess you could say. And it tells us how stiff, how rigid the liver is. The lower the number, the better. So 5.5 or less is normal. Above 5.5, we're starting to talk about being in what we call between F0 or 0 stage and the first stage of fatty liver, F1. And the higher that it goes, the more correlated to more advanced liver disease, or the more advanced fatty liver disease, like the more aggressive version, NASH. Or even, we've diagnosed patients eventually, right? Because this is not diagnostic. This is not, we can't use it to 100% by itself tell us whether a patient has, fatty liver disease or NASH or cirrhosis, but used in clinical context and with other tools that we have, definitely can get to that diagnosis. And so we've definitely found patients with cirrhosis that walk through our, come in for a free fiber scan either here at our clinic or even in the community. And, 0 symptoms. And that's the scary thing about even what we call well-compensated liver cirrhosis, because some of these patients ended up going on into our studies, and we did other, as part of the clinical trials, they got, free MRIs or biopsies or whatever, and it confirmed that they truly indeed had liver cirrhosis, but it was just what we call well-compensated, meaning a ticking time bomb. Well-compensated liver cirrhosis meaning that there was absolutely no symptoms, right? So the symptoms of liver cirrhosis would be water in the stomach, swelling at the bottom of the stomach or on the sides of the stomach, swelling or water in the lungs, right? A little shortness of breath, swelling in the ankles, that kind of thing. Liver cirrhosis creates a problem with how we process fluids in the body, amongst everything else. Confusion, right, is a symptom of uncompensated or decompensated liver cirrhosis. And as a hospitalist or prior hospitalist, I would see patients come in all the time with decompensated liver cirrhosis and these other symptoms, fluid in their lungs or fluid in their bellies, which we would have to take out. And so we have patients with well-compensated cirrhosis that are newly diagnosed cirrhosis and never had a symptom before, and we're able to get them to the proper feedback, of course, to their primary care physicians and get them to the proper specialty support. Thankfully, here at STRI, we have our founder, CEO, Dr. Rashmi Patil. She's our hepatologist, our guru in liver disease, and is our mentor and our primary oversight here, and provides us with that reinforcement to help get these patients into the right studies. Number one, if they're a candidate or if they want to be part of a study, and if not, then getting them to the care that they need. So what can we do? A big part, like I've been, preaching, is preventing, right? Or if we do, let's say you come into our clinic and you enroll in a study with us, or we do a fiber scan and we say, hey, I really think you probably have the more aggressive form of fatty liver, NASH, which I'm in that spectrum as well. We talk about preventing getting fatty liver disease, but let's say we have it already. Well, let's stay at that level, or let's get better, right? If we're F2 disease, let's not go to F3 or F4. Let's not advance to the more serious ones. Let's go down, right? And so that's possible. The liver is a super forgiving organ. I mean, it just has such capacity to regenerate and to heal itself. And so exercise is a huge part of preventing it or maintaining where we're at and potentially reversing it. So we do see reversal happen with diet and lifestyle changes. Even if we're seniors, right? Even if we get older, at any age, of course, as we get older, if you have, certain metabolic issues or certain disease issues, talk to your doctor before you start an exercise program. Please start slow, right? Go low and slow and work up slowly, preferably with a professional, right? But exercise is a huge part. And then not only for fatty liver disease, right? Or for prevention, but for prevention of something like diabetes or keeping our immune system healthy. We know that exercise can decrease the risk of certain cancers. It definitely decreases our risk of heart disease and other cardiovascular and neurovascular issues, reduces our risk of stroke. And so I have patients all the time, even myself personally, we started an exercise program, or we started dietary and lifestyle changes, but especially the exercise, and we don't see results, right, in our weight, for instance, quickly. I would tell somebody, if they're exercising, especially aerobic type exercise, right, getting the heart rate up, even if you're not losing weight, right, which the majority of the weight comes from dietary changes, by the way, but even if you're not losing weight, you are providing yourself with a huge benefit, right, a huge benefit to your internal organs and to your brain and everything else, whether or not you see the weight loss. So I would encourage you, keep it up, be safe about it, right, but keep up and don't give up yet. Don't, like I said earlier, I was like, start, slow, right? Don't, if you've never run a 5K before, or never even ran around the block, don't sign up for a marathon next week, right? Because overdoing it is one of the big things. At least I'll speak personally. When I've tried to, get on track, and starting with too much too quickly can be a problem. Showing up right is a big deal. Talking to your doctor, for instance, and letting he or she know, hey doc, I want to start an exercise program, or I have a family history of type 2 diabetes, or a family history of cirrhosis, or can you check me for fatty liver disease, XYZ. Showing up to the doctor's office or to the gym or to a dietitian, right, is one of the hardest parts. Being hard on yourself, right? Take a friend, be nice to yourself, involve others in your progress or in your lack thereof. Reach out for accountability. We're here to help you as well. And like I said, we have many patients that aren't involved in studies that just come back to us once every 6 months or once every year for a free fiber scan. And each time we encourage them and we provide them with that support. Also know that any studies that you get done with us, or any information, we talk to your PCPs or your specialists. We can provide them with the results of whatever we get, imaging studies, whatever, lab studies, and we're constantly in contact with the community PCPs. Diet is the cornerstone, right? And notice that the food plate has changed. I was born in '86, and I remember in the '90s we had the food pyramid, which used to have kind of like the grains and as the basis. That's not anymore. We know that kind of limiting our grain intake and limiting our carbohydrate intake as a whole, and really making the green leafy vegetables, the fruit and vegetables, as our primary the basis of our food pyramid and the foundation of what we eat is one of the most important things. And being creative with how we eat as well. I definitely have had something similar to this. We can make McDonald's at home. It's true. Home cooked meals are going to be healthier in general. And then one last quick tip is that liver cleanses. Just we get a lot of questions from patients all the time. Don't do them. These supplements that you might get on Amazon. I love Amazon, by the way. But supplements or liver cleanses, we don't know what's in them. And to be honest, I wonder if the companies that create them and promote them as liver cleanses know exactly what's in them. They're not FDA regulated, and oftentimes there is no regulation governing what's inside of them, right? So could they be hepatotoxic, liver injuring, liver damaging, have chemicals or medications even sometimes in them that you may not even know that you're consuming. So I strongly recommend against the traditional liver cleanse, especially if they're involved some kind of herbal supplement or type of thing. Eating a balanced diet, reducing the amount of alcohol that we drink, exercise, eating healthy fats in our diet, like the fat found in avocado, right? Walnuts and almonds and those kind of things. That's healthy. Fish, that's healthy for us. And then our liver, if we leave it alone, if we give it time to regenerate, right, it will heal itself. And so again, here at STRI, we offer the free liver screenings. You guys can call in for an appointment to come in for a liver screening. Sometimes we have walk-in appointments available. We also are at community events. We host events at doctors' offices. We're partnered with quite a few doctors in the area, both primary care and specialty care. And we're always looking for a way to reach out to the community and provide resources on metabolic disease in general and prevention, but then also specifically in the area of fatty liver disease. We have two clinics here in the Valley, one here in Edinburgh. We're located at 2502 West Trenton Road in Edinburgh. We're here in the Cornerstone Plaza. It's a big kind of silver building called STRI. We're facing the Trenton side. And then we have a practice in Brownsville as well with our principal investigator over there, a friend of mine, my colleague, Dr. Dimple Desai, who's fantastic and will take great care of you over there as well. We also have a couple sub-investigators, 2 nurse practitioners who are fantastic as well, Ms. Gracie and Mr. Frank, who together we form the clinical team, and as well as our nurses and our full complement of research staff. And exactly, and remember that everything is free. Everything is always voluntary for the patient. You can enroll or disenroll at any time if you happen to come on with a study for us. Most oftentimes the drug company will offer the patients a small stipend, for their time, in the form of like a gift card usually type of thing each time that they come in for a clinical study if they get enrolled. And ultimately what the patient is going to be doing, and then what we're trying to do, is contribute to hopefully finding the first medication to treat fatty liver disease. There's not anyone approved yet, and hopefully with the research that we're doing or contributing to, and that the patients are heroically contributing to, which we're so thankful for them. Hopefully it'll lead to a medication that can interrupt this process and provide some relief for patients. So I'm always available for questions or any comments, concerns. I'll ask Mr. Davis to put my contact info in the comments, and the contact info for STRI as well. And we're here to serve you guys. And here's some of my references.